to the deep dive. Today, we're getting into a really key group of drugs, miotics. You might also hear them called parasympathomimetics.
That's right. And they're super important for eye health, especially, managing conditions like glaucoma.
Exactly. We're working from a great resource today, Miotics for Glaucoma and Other Uses, which really lays things out clearly.
It does. And for everyone joining us on KMR Advise, our plan today is pretty straightforward.
Yeah.
We want to pull out the must-know info on miotics.
Yeah, like how they work, what they're actually used for, because it's not just glaucoma, and the really critical things you need to watch out for.
Consider this your focused briefing. We'll break it down so it makes sense and hopefully sticks.
Definitely. So if you're following along on KMR Advise, maybe even have that document handy, this is all about making these core concepts clear. Because understanding miotics, it's fundamental.
It really is. You're going to encounter these situations in practice. Knowing the mechanisms isn't just academic, it's practical.
Okay, so let's dive right in. The basic question first. What exactly are miotics?
Well, in simple terms, miotics are drugs designed to mimic what your parasympathetic nervous system does naturally.
The rest and digest system.
Precisely that one. It has significant effects on the eye, hence the name parasympathomimetics. They mimic the parasympathetic system.
Okay, so they're kind of pushing the eye towards that rest mode. And that relates directly to eye pressure, doesn't it?
Yes, exactly. Their main job, probably the most common use, is managing glaucoma.
Right. Let's talk about open-angle glaucoma first. How do they help there?
Okay, so with open-angle glaucoma, think of the eye's drainage system, the trabecular meshwork, as being a bit sluggish or partially blocked. Miotics help to, open up that drain. They increase the outflow of the fluid inside the eye, the aqueous humor. More outflow means less pressure building up inside.
Like clearing a slow drain in a sink to lower the water level. Makes sense.
That's a good analogy.
Now, what about angle closure glaucoma? That sounds more acute.
It is. Angle closure is an emergency situation. The drainage angle itself gets physically blocked, often by the iris.
So what's the role of miotics then?
In that emergency, miotics are used to quickly constrict the pupil. That's called meiosis.
Meiosis, right.
And that constriction can actually pull the iris tissue away from the drainage angle, physically opening it up again and causing a rapid drop in that dangerously high intraocular pressure, the IOP.
Wow. Okay, so it's a very direct, almost mechanical effect in that case.
It can be, yes. A crucial intervention.
But it's not just glaucoma, is it? I saw some other uses mentioned in our source.
No, not just glaucoma. They're also used sometimes after an eye exam where your pupils were dilated with mydriatic drops.
Ah, to reverse the dilation?
Exactly. Or after certain eye surgeries. Miotics counteract those dilating drops, bringing the pupil back to normal size faster. Sort of like an antidote to the dilation.
Okay, hitting the brakes on pupil dilation. Interesting. And then there was something called accommodative esotropia in kids.
Yes, that's quite specific. It's a type of inward eye turn, or strabismus, in children that's related to their focusing effort. A particular miotic, ecothiopate, can sometimes be used in these cases to help improve the eye alignment. It's a specialized pediatric use, really.
And the really surprising one, for me anyway, was pilocarpine for dry mouth. Xerostomia. That seems totally unrelated to eyes.
It does seem that way at first glance, but it highlights that these drugs, these parasympathomimetics, affect more than just the eye. They act on certain glands, too.
Like salivary glands.
Exactly. Pilocarpine can stimulate saliva production, so it's sometimes used, often off-label, for dry mouth caused by things like Sjogren's syndrome or maybe after radiation therapy. It broadens the scope, doesn't it?
It really does. Okay, so we know what they are and broadly what they're used for. How are they classified? How do they actually do what they do?
Good question. They're generally split into two main groups based on how they work. Their mechanism of action.
Okay.
You have the direct-acting cholinergics and the indirect-acting ones, which are cholinesterase inhibitors.
Direct versus indirect. Let's unpack that for the KMR Advise audience. What's the difference?
So the direct-acting ones, like pilocarpine or carbachol, are pretty straightforward. They bind directly to the cholinergic receptors in the eye, specifically muscarinic receptors, and activate them, like a key fitting straight into the lock.
Okay. And you mentioned some brand names, especially for our listeners in India.
Right, good point. For pilocarpine, you might see pilopine or asoptocarpine. For carbachol, maybe carbistat or myostat. Useful to recognize those.
It's definitely helpful. So direct actors are like the key itself. What about the indirect ones?
The indirect acting miotics, like ecothiopate or maybe physostigmine, work differently. They don't directly hit the receptor. Instead, they inhibit an enzyme.
Which enzyme?
Acetylcholinesterase, often just called ACE.
And what does ACE normally do?
Its job is to break down acetylcholine, which is the natural neurotransmitter that activates those cholinergic receptors.
Ah, so by blocking the enzyme.
Exactly. By inhibiting ACE, these drugs let acetylcholine hang around in the synapse for longer, so it keeps stimulating the receptors. More stimulation, stronger effect. You might see ecothiopate as phospholine iodide or physostigmine as ezerine.
So it's like stopping the cleanup crew, letting the natural messenger do more work for longer?
That's a great way to put it. Prevents the natural off switch from working as quickly.
Got it. One activates directly, the other boosts the natural activator. Okay, let's really dig into the mechanism of action, the MOA, step by step. Step 1.
Step 1 is that initial receptor activation. So for direct agents like pilocarpine, it binds straight to the M muscarinic receptors on the eye muscles.
M receptors.
Okay. This binding does two main things. First, it makes the sphincter pupillae muscle contract. That's the muscle that makes your pupil smaller. Result, miosis.
Pupil constriction. Check.
Second, it also makes the ciliary muscle contract. Now this is key for glaucoma because contracting the ciliary muscle pulls on the trabecular meshwork, sort of opening it up.
Improving that drainage pathway we talked about.
Exactly. And for the indirect agents, like ecothiopate, as we said, they inhibit ACE.
Right, letting acetylcholine build up.
Yes, in the synaptic cleft, that tiny gap. So you get more acetylcholine stimulating those same MUR receptors for a longer time. Same ultimate effect, different route to get there.
Okay, step 1. Activate the receptors, one way or another. What happens next? Step 2. The clinical effects.
Step 2 is what we actually see happen. First, miosis pupils constrict. Less light gets in. Second, and this is a big one for glaucoma, IOP reduction. Intraocular pressure goes down.
Because the drain is working better.
Precisely. That enhanced aqueous outflow through the trabecular meshwork and another structure called Schlemm's canal lets the fluid escape, lowering the pressure.
Makes sense. And there was a third effect, accommodation spasm.
Yes. That ciliary muscle contraction we mentioned, it's also involved in focusing your vision, especially up close.
Ah, okay.
So when miotics make it contract, it can cause a temporary spasm of accommodation. This makes focusing, particularly on near objects, difficult. Leads to blurred vision for close work.
That sounds like something patients really need to know about.
Oh, absolutely. It's a crucial counseling point, especially regarding things like reading or driving, particularly just after they've used the drops.
Right, so constricted pupils, lower pressure, maybe some blurriness up close. That covers the immediate effects. How does the body stop these effects? Step 3. Termination.
This is where we see a really important difference, especially between pilocarpine and ecothiopate.
Okay.
Pilocarpine gets broken down fairly quickly, right there in the eye tissues. Its effects usually last, say, 4 to 8 hours. Relatively short-acting.
4 to 8 hours. Got it. And ecothiopate.
Ecothiopate is different. It forms a very strong, essentially irreversible bond with the acetylcholinesterase enzyme.
Irreversible. Wow.
Yeah. The enzyme is knocked out. The body basically has to make new enzyme molecules to get back to normal function. So its effects can last for days, even weeks sometimes.
Days? That's a huge difference from 4 to 8 hours. Pilocarpine's a quick visit. Ecothiopate moves in for a while.
Exactly. And that has major implications for how they're used and dosed.
Which leads perfectly into pharmacokinetics, how the drugs move through the body. Tell us about that contrast.
So pilocarpine, as we said, short duration, 4 to 8 hours. It also has a pretty quick onset, maybe 10-15 minutes you start seeing effects. It's mostly metabolized locally and then excreted by the kidneys.
Quick in, quick out?
Pretty much. Ecothiopate, on the other hand, might take a little longer to fully kick in, maybe 30 to 60 minutes. But because of that irreversible ACE inhibition, its effects linger for days.
And how is it broken down then if it binds so tightly?
It's eventually broken down by other enzymes, particularly in the blood plasma, and then the inactive bits are cleared by the kidneys. But the effect lasts until new ACE is made.
So kinetic summary. Pilocarpine, rapid onset, short duration. Ecothiopate, slower onset, much, much longer duration.
You got it. And that difference, it's a key clinical pearl for everyone listening on KMR Advise. Think about dosing.
Ah, right. If pilocarpine only lasts a few hours.
You often need to use it multiple times a day.
Yeah.
Maybe 4 times daily, which can be, a bit inconvenient for patients.
Yeah, compliance could be an issue.
Whereas ecothiopate, with its long duration, can often be dosed just once a day. Much easier for many people to stick with.
That's a really practical point. Okay, super important differences there. Now, no drug is perfect. What about side effects? Adverse effects?
Right. We can generally group them into ocular effects, things happening in the eye, and systemic effects, things happening elsewhere in the body if the drug gets absorbed.
Let's start with ocular. What are the common ones?
Well, we mentioned the blurred vision from the accommodation spasm.
Hmm.
Also, patients might get a brow ache, kind of a dull ache above the eye, again from that ciliary muscle working, and temporary myopia or nearsightedness.
All related to that muscle contraction.
Mostly, yes. These can often be managed by adjusting the dose down a bit. And again, caution about driving or tasks needing sharp vision is important until they adapt.
Okay. What if the drug gets into the bloodstream? Systemic effects.
Because these drugs mimic the parasympathetic system, you can get parasympathetic effects elsewhere. Think esology, GE, sometimes salivation, lacrimation, urination, defecation, GI upset, emesis. More commonly, maybe diarrhea, increased sweating, sometimes a slow heart rate, bradycardia.
Sounds unpleasant. Is there anything you can do if those systemic effects get bad?
Yes, if it becomes a significant systemic issue, the antidote is atropine. Atropine is an anticholinergic, so it blocks the effects of excess acetylcholine.
Good to know there's a reversal agent. Now, the source also flagged a couple of potentially more serious, maybe longer-term issues. Cataracts.
Yes, specifically with ecothiopate. Prolonged use has been linked to cataract formation. It's thought to affect the lens proteins somehow.
So you wouldn't want someone on ecothiopate forever if you could avoid it.
Generally, no. It's a major reason why its long-term use is often limited, especially if other glaucoma treatments work.
And the other one was retinal detachment.
Yes, another serious but thankfully less common risk. It seems to be a bit higher, particularly in people who are very nearsighted, especially if they're using miotics after eye surgery. Screening for risk factors is important here.
Okay, definitely serious points to keep in mind. Are there people who absolutely should not use miotics? Contraindications.
Yes. We talk about absolute contraindications, definite no-goes, and relative ones used with caution.
What are the absolute ones?
Acute inflammation inside the eye, like iritis or uveitis. Miotics can actually make that inflammation worse. Also, ecothiopate contains iodide, so anyone with a known allergy to sulfur compounds shouldn't use it.
Okay, inflammation and allergy. What about the relative contraindications? Use carefully.
Right. Conditions like asthma or COPD, because if the miotic gets absorbed systemically, it could potentially cause bronchospasm tightening of the airways.
Ah, that parasympathetic effect again.
Exactly. Also, caution in patients with peptic ulcer disease, as miotics can increase stomach acid secretion. So it's all about weighing risks and benefits carefully in those patients.
Really highlights the need for a good patient history, doesn't it?
Absolutely essential.
What about using miotics alongside other drugs? Any key interactions for our KMR advised listeners to be aware of?
Definitely. You can get additive effects.
Mm.
If someone's taking another cholinergic drug, maybe something like Dunpezil for Alzheimer's, adding a miotic could increase the risk of those systemic side effects we talked about. Too much cholinergic activity.
So avoid stacking similar drugs. Makes sense.
Conversely, anticholinergic drugs, like atropine itself, will oppose or counteract the effects of miotics. They cancel each other out.
Okay. What about other glaucoma drugs, like beta blockers? Timolol is common.
That's an interesting one. Beta blockers like Timolol also lower eye pressure, but through a different mechanism. When used with a miotic like pilocarpine, they can actually have a synergistic effect.
Meaning they work better together than alone.
Exactly. The combined IOP lowering can be greater. So combination therapy is quite common in glaucoma management.
That's useful clinically. Now, there was a specific exam tip in the source about succinylcholine. It sounded important.
Yes, this is a classic high-yield point, especially if you're thinking about anesthesia. Succinylcholine is a muscle relaxant used in surgery. It's normally broken down quickly by an enzyme in the blood plasma, plasma cholinesterase. But guess what inhibits that enzyme too?
Let me guess. Ecothiopate.
You got it. Because ecothiopate inhibits cholinesterases, including the one that breaks down succinylcholine, it can make the muscle relaxation effect of succinylcholine last much, much longer, potentially dangerously long.
Wow. So if a patient on ecothiopate needs surgery with succinylcholine?
The anesthesia team absolutely needs to know beforehand. It's a critical piece of information for patient safety. Definitely remember that one for exams and practice.
Definitely noted. Okay, let's talk dosage and maybe some final clinical pearls. What are some typical doses?
For pilocarpine and glaucoma, it's often 1 or 2 drops of a 1% to 4% solution, usually 4 times a day because of its short duration.
Like the frequent dosing.
For the dry mouth use, xerostomia, it's an oral tablet, usually 5 milligrams 3 times a day.
And ecothiopate, given its potency and duration.
Much lower concentration, maybe 0.03% to 0.125% solution, and typically just once daily. usually reserved for glaucoma cases that aren't responding well to other treatments.
And that pediatric note, ecothiopate for accommodative esotropia.
Yes, it's sometimes preferred for that condition in kids, but again, really important to monitor children closely for any systemic side effects. They can sometimes absorb more drug relative to their body size.
Makes sense. Careful monitoring in kids always. What if someone takes too much? Overdose or toxicity?
Okay, two scenarios. Systemic overdose leads to a cholinergic crisis. Signs are like extreme versions of the side effects: severe diarrhea, lots of salivation, maybe pinpoint pupils, dangerously slow heart rate, sweating.
Sounds serious. What's the management?
Immediate action. Atropine is the antidote, given intravenously, usually 0.5 to 1 milligram. Plus, supportive care managing breathing, blood pressure, etc.
Okay. And what if the overdose is just in the eye? Too many drops?
Ocular overdose would likely mean severe miosis, maybe eye pain or ache, significant blurred vision, in very rare severe cases, potentially retinal issues. Management is mainly to stop the drug immediately and use supportive lubricating drops for comfort.
Stop the drugs, support the eye. Got it.
Now, black box warnings. Those are always important.
Yes, the most serious warnings. Ecothiopate carries them.
Remind us what they are.
The risk of cataracts with prolonged use and the increased risk of retinal detachment really underscores why it's not usually a first-line or long-term choice if alternatives exist.
And there was a caution note specifically for pilocarpine, too.
Yes, regarding asthma. Even though it's an eye drop, some can be absorbed systemically. In someone with asthma, that systemic cholinergic effect could potentially trigger bronchospasm. So use with caution in asthmatics.
Good point. And finally, that practical tip about pilocarpine and stinging.
Right. Pilocarpine drops can sometimes sting a bit when put in the eye, partly due to their pH.
A simple tip for patients is to keep the bottle in the refrigerator. The cool drops often sting less. It can really help with comfort and making sure they actually use their medication.
That's a fantastic, practical pearl. Great tip for anyone advising patients. Okay, to wrap this up for everyone on KMR Advice, let's run through that final exam checklist. Make sure we've hit the key points.
Let's do it. Quick fire. First, mechanism of action. Can you differentiate direct agonism, like pilocarpine, from indirect ACE inhibition, like ecothiopate?
Check. Direct key versus stopping the cleanup crew.
Second, glaucoma uses. Do you understand how they lower IOP? By increasing outflow via the trabecular meshwork and Schlemm's canal.
Check. Opening into drain.
Third, adverse effects. Can you name key ones, like blurred vision, risk of cholinergic crisis systemically, and the cataract risk with ecothiopate?
Check. Ocular, systemic, and long-term risks.
And fourth, contraindications. Remember the important ones: acute iritis and caution with asthma.
Check. Absolute no-goes and relative cautions.
Excellent. If you're comfortable with those 4 points, you've got a solid handle on the core concepts of miotics.
Perfect. So in this deep dive, we've covered a lot of ground on miotics, their uses from glaucoma to dry mouth, how they work, the different types, side effects, who shouldn't use them. It's quite a bit.
It is, but having this fundamental knowledge is so important for you as future healthcare professionals. We really hope this discussion here on KMR Advise has clarified things for you.
We definitely encourage you to go back to that source doc, Miotics for glaucoma and other uses, or look at other resources to really cement this information.
Absolutely.
And here's something to maybe ponder after listening. How does that big difference in duration of action between the short-acting pilocarpine and the long-acting ecothiopate really influence how you choose between them for different patients or situations? Think about lifestyle, adherence, severity of disease.
That's a great question to consider. And for more deep dives like this one, covering key medical topics, please do share this with your friends and colleagues, especially fellow medical students.
Yes. And be sure to subscribe to KMR Advise on YouTube and definitely hit that bell icon so you don't miss our next exploration.
We'll keep bringing you these focused discussions.
We'll be back soon with another deep dive into essential pharmacology and medical knowledge right here on KMR Advice. Until then, keep learning and stay curious.